the entrance is slightly inflamed as well because of the trauma, which completely seal the entrance. Now, we can sometimes, as we age, get collapsed ear canals. Collapsed ear canals is when typically the outer third of the ear, the cartilaginous portion, that's made up of cartilage. The cartilage weakens, and the cartilage provides obviously rigidity, it provides the contour, the shape of the ear canal. And if that cartilage weakens and buckles, the canal can collapse. The inner 2/3 of the ear canal is made up of bone. Now, it's less likely for the bone to collapse. It is possible, but bone's rigid, unless there's some osteomyelitis, an infection of the bone starts to disintegrate and decompose, then you can potentially get a collapsation of the bony part. But a collapsed ear canal normally is at the entrance of the cartilaginous portion. Another potential cause is it's the posterior cartilage on the ear canal. So when we say posterior, we mean the back canal wall. As that cartilage nearer to the entrance, it can continue to grow. So the cartilage at the tip of the nose and the ear can continue to grow, and that cartilage overhangs, and it kind of falls over. It's overextended itself. So there is surgery for that. The cartilage can be trimmed and kind of then realigned back into position. But canaloplasty is not always performed. It's obviously surgery. It's not something that you just, if it's avoidable, it's always recommended to avoid it. It could just be that in those instances that the patient has their ears cleaned out regularly. If they develop ear infections as a result, or they can't hear as a result, then so it's becoming a day-to-day issue, then yeah, possible surgery is a good idea. But otherwise, it's just something that patients manage, and they have their ears cleaned as and when necessary. As long as, if it's really frequent that they have to have their ears cleaned, then again, there's another potential reason to have the surgery. So I've managed to remove the outer third, and it was very difficult because I was having to use the endoscope, as I was in the left ear, to stretch the ear open. So under normal resting state, the canal entrance is completely shut. I'm having to pull the ear back. You may have seen it open there. And I'm actually doing that using my right hand. So my right hand is also holding the suction probe, as you can see in the ear now. So as I'm holding that in my right hand, I'm also pulling the ear back and up. And when you pull the right ear, and either ear, backwards and upwards, what it does, it stretches the ear and straightens it. So it has a dual function. And then to keep that ear open, I'm then inserting the endoscope with my left hand, that's in my non-dominant hand, and I'm positioning, in the case of the right ear, the left-hand side of the tip of the endoscope. I'm pushing the ear canal to the left, so I'm keeping it open. It's almost like a doorstop. And whilst the endoscope's acting like a doorstop, I also have to use the endoscope to visualise the wax. So it's doing two things, my left hand. And then my right hand, because the ear canal's open, I'm inserting the instrument into the ear without making contact with the canal wall, because we don't want to bump up against the canal wall. You can see that entered the middle. And I can start removing wax. So you're having to use bilateral coordination when you use an endoscope, using both hands simultaneously and in synchrony. And for that reason, sometimes endoscopic technique, it's difficult to teach and train. I've been doing the training courses with Clearwax and my other company since 2015, and even very experienced practitioners, they can really struggle and ultimately reject the endoscope. But if you can master the endoscopic skill, there's no better technique of removing earwax. And you've seen all the videos. You don't get that view with any other visualization technique. So other visualization techniques available